Is the mic on? All right. So Warren, if you want to grab a handout, that'll be helpful. So for those of you that are listening at home, the handout that was emailed out is what I'm going to go by. I'm not going to use the slides, so you'll want to take the time to find that email and open up the document on it. And all you're going to get at home is the audio, so you want to have that slide in front of you while you're listening, if you're listening at a later point. So when looking at this chapter, guys, it looked like a lot of it was review for you guys. A lot of the physiology, a lot of the, you've already had a majority of this stuff, but it was kind of putting it all together. So since a lot of it was review, I used a little different format. I went ahead and I put together an outline. I pulled a lot of this outline from a lot of the handouts I used when I was going through school, and it was a better way for me to learn as opposed to going through these slides. So hopefully you can use it as a resource if you need something supplemental. It does follow a majority of the path that your slides would also be covering. If you take a look at the first page, these are the National EMS Education Standard competencies. So along with those competencies, you also have page numbers that correspond, so you can look into different things further if you so desire. These were provided in the instructor notes that came with your slides. As we dig into it deeper, the bigger print stuff is the stuff I've added. When we get to some of the stuff at the end, it has some smaller print. That stuff I copy and pasted out of the instructor notes because I didn't want to spend time on it. At the very end, I have a worksheet. This is a worksheet I used when I was going through school. My instructor provided it. It's a dyspnea worksheet, and it kind of outlines for you red flags, pertinent findings that you may have, as well as special considerations. So it kind of breaks it down into what kind of history they're going to have, what you're going to see, and then how you treat these different disease processes when treating a respiratory emergency. So figure we can go through the outline, and then at a later point we can kind of look at that worksheet and fill it in together and hopefully get a nice little comprehensive thought process for some of these common emergencies. So bottom of the first page, I wrote FIC principle. Just like everything, they like to break stuff down into threes. Eric said, could you forward it to me?
They're taking care of it.
Okay. So FIC principle, they break everything down into threes. And the basis of this principle is that for respiration, you have to have three main components. So next to that, if you would write onloading, circulation, and then offloading. So onloading, you have to have available O2. Bottom of the first page there, Brett. Yeah. Circulation, you have to have the volume and a good pump. So you have to have a full container and a pump that can move that blood. So that's your delivery system of the available oxygen, the first principle. And the third part of that principle is offloading. So that oxygen has to be delivered at those different tissue sites. So you have to have the onloading, circulation, and then the offloading. The next thing I've written down is dyspnea versus shortness of breath. And does anybody know the difference between dyspnea and shortness of breath? So dyspnea is what you observe, where shortness of breath is a sensation. So dyspnea is when you walk in and you see that person and they're in a tripod position, they have an increased work of breathing, that's dyspnea. Shortness of breath is someone who says, I feel short of breath. You put them on the SpO2 sensor and it says 98%. They have the sensation of feeling short of breath, but dyspnea is the actual increased work of breathing. So let's go start the outline. And then your slides, they had a lot of anatomy review, and about all I got out of it was upper airways classified as structures above your vocal cords, lower airways, everything below the vocal cords. But it dove into it a little deeper, so there's some page numbers there if you want. So respiration. Ventilation refers to the movement of air from the atmosphere into and out of the lungs. So inhalation is the active portion, and exhalation is the passive portion. The way I think about this is I think about it like a syringe. So if you had a spring on the end of that plunger on a syringe, the active portion would be pulling against the spring to pull the plunger back out of that syringe. Same thing happens with your diaphragm. The active portion pulls your diaphragm down, and that reduction in pressure within your lungs, within your diaphragm, within your thoracic cavity, from the diaphragm moving down, sucks air in. Lungs work the same way. So then if you were to let go of that spring, it would pull that plunger back in and the air would rush out. That's the passive portion. So something to think about. Moving into bronchial resistance. So usually resistance inside the bronchioles is very low. Bronchial resistance is determined by, and on that first blank, I want you to write in parasympathetic nervous system. Does anybody have a pen? Your second blank is sympathetic nervous system. So if you think about your bronchioles and you picture them, they're wrapped in a bunch of smooth muscle, if you will. And that parasympathetic nervous system innervates those to contract, or the sympathetic nervous system can relax them. Two factors that increase resistance. The first one is going to be the smooth muscle contraction. In line 2 there is going to be excessive mucus production or inflammation. So smooth muscle contraction for the first one, and 2 is excessive mucus production or inflammation. So when we talk about controlling the respiratory system, it's controlled by the medulla and the pons for the inspiratory and expiratory neurons that fire at opposite times, creating your respiratory pattern. So real quick, the medulla and the pons, we're talking about the brainstem. So the medulla is in charge of the normal rhythmic pattern, and the input comes from the chemo and the baroreceptors. Are you guys familiar with what chemoreceptors are? Yeah. So they're reading what your pH is at, whereas the baroreceptors, just like a barometer, they're sensing pressure changes. And as in your notes it says, pons' primary function is to control duration of inspiratory cycle. So it indirectly controls your rate. So cerebral chemoreceptors, this is your primary control of the respiratory drive. And you have 2 blanks in there. The medulla responds to changes in the concentration of the hydrogen ions. And it's looking at the hydrogen ions of the cerebral spinal fluid. Sorry. So increased CO2 means you're more acidotic. Where we would see an increase in CO2 and like your Untitled CO2 sensor on your monitor, right? I think it comes up purple. But that increase in hydrogen ions means you're more acidotic. We'll get into a little bit more. And a lot of this review on the physiology is because your first 40 slides or so in the slideshow reviewed a lot of this stuff. Seems like there's a lot of repetition in this in these chapters. So then you have your peripheral chemoreceptors. They exist in your carotid and aortic arteries. So have you guys ever heard of people using a carotid massage for a vagal response? We usually don't use it in the field because patients get a little weird if you start rubbing their neck, right? But that's another option. So as opposed to the Valsalva technique that we usually use. So as you see there, it says hypoxic drive or secondary or backup. So these peripheral receptors are responding to oxygen levels as opposed to your pH. I have yet to see it in our EMT test that doesn't ask you about the hypoxic drive. So also known as the secondary or backup. What population do we see this? COPD. Yep, there you go. Good. Another factor is pulmonary stretch receptors. They're located in the bronchi and alveoli. These receptors control overinflation. That's what will go in your blank there. And they control the overinflation by sending inhibitory pulses to the inspiratory center of the pons once a certain degree of stretch occurs. Next line. You guys talked about the 12 cranial nerves at all? Has that been covered? So two of your 12 cranial nerves are the vagus and the glossopharyngeal nerves. And they're taking the input from your chemoreceptors and the carotid and aorta that terminate the medulla. So they go back to your brainstem. Phrenic nerve. I got a note there, it exits at C3, C4, and C5. So that's applicable to us if we have a high cervical fracture, and potentially a patient could lose control or the ability to innervate their diaphragm and their intercostal muscles. In other words, it would need to be supported by mechanical ventilation. Next, we got some physiological concepts. I was looking at this morning. I have elasticity versus lung compliance. I think of elasticity as kind of the recoil or rebound, versus the compliance is more the ability to stretch. So we talk about how's the compliance when we're bagging somebody. How much resistance are you feeling? Surface tension. Bump down to surfactant. Surfactant, cells within the lungs that create phospholipids. Substance that acts like a detergent in the inner space between water molecules and the alveolus, therefore weakening the bonds, reduces the surface tension, tendency for the alveoli to collapse. Something kind of interesting there is blood deactivates it, but surfactant is something that the body can reproduce. Tidal volume, I have it noted in there that each tidal volume is about 500 mils. Your lungs obviously hold a lot more oxygen, have a lot more volume than that, but that's what we're exchanging when we bag our patients. So dyspnea causes. So atelectasis. You guys gone over what atelectasis is? So atelectasis, I got a blank for you there, and it refers to the collapse of a lung and or alveolus. So atelectasis refers to the collapse of a lung and or alveoli. So there's two types of atelectasis. First is compression, which is more often than not secondary to trauma. Other things that can cause it are tumors or abdominal distension or swelling in the interstitial spaces. Absorption atelectasis is what we more commonly see in our different disease processes. So it occurs as a result absence of air in the alveolus. And essentially, if you get like a mucus plug or something blocking the way for that air to escape the alveoli, it'll diffuse out of that space, can essentially collapse upon itself. So that's the more common one we see with like our obstructive pulmonary diseases. I was looking at pulmonary hypertension. That should have been moved out there a little bit. So pulmonary hypertension is essentially increased pressure inside our lungs and increased blood pressure. And I have 3 different causes down there. But kind of the big takeaway is under the problems, under the core pulmonal, is essentially right-sided heart failure. So you have that increased resistance inside your lungs, and it's making the right side of that heart work harder. Can lead to hypertrophy of the right side, and eventually right-sided heart failure. Lose the effectiveness of that right side of your heart. So moving on, I got abnormal breathing patterns. I always kind of find these interesting. We were talking about these the other day, but so the first one on there is the Kussmaul respirations. So Kussmaul respirations are deep and rapid. Under A there for you. Deep and rapid. An example would be a DKA patient. So they're using their respiratory system as a compensatory mechanism to try to blow off the increased ketones there. The next one is pronounced chain Stokes respirations. And so chain Stokes respirations are usually secondary to increased ICP. So most likely secondary to like a traumatic brain injury. And they're an inappropriate response to the acid base or the acid levels, increased CO2 in your body. Your brainstem cannot respond appropriately because of the increased pressure. So what you see with those is you'll see a fast, rapid respiratory rate, and your body will overcompensate. So it blows off too much CO2. Like if we had a CPR and we bagged somebody down too low, we were bagging too fast, we'd blow off too much of their CO2. And essentially that's what the body's doing because it can't regulate effectively. So then it goes the other extreme where they almost become apneic, and then they once again become too acidotic. So it's the body trying to keep up, but it's unable to do it as it should appropriately because of the increased intracranial pressure. The blank there characterized by, you can put in there deep and shallow respirations. So alternating periods of deep and shallow respirations. The next one, CNH, is worse than chain Stokes. Even greater ICP. So it's usually indicative of preherniation. Do you guys know what tachypnea is? When someone says tachypnic? Yeah, so it's fast breathing, just like your tachycardia, tachypnic, tachypnea, the same thing, fast respirations. The next one I have is ataxic, erratic breathing without predictive patterns, and apneustic, which is just prolonged inspiratory efforts. You know, John, I don't know how they measure the pulmonary hypertension. I think it's just persistent upon usually that disease process, maintaining those higher pressures. It's usually secondary to extra fluids within the lungs there that create that pressure. Unless anyone... Mm-hmm. Yeah. So the other example on there, I believe, was like a left to right shunt. So extra blood being pushed to that right side and circulating within the lungs, or pulmonary, different causes for pulmonary edema increases that pressure. So kind of the main takeaway is that increased workload on the heart, though. I don't know about the waveform changes on the capnography. I know you can see some EKG changes, so you'd see like an increase that because of that hypertrophy, you could see a bigger P wave, possibly a notched P wave, or sometimes indicative of the extra workload on the right side of the heart. Everybody good? Keep going? You guys want to do some jumping jacks or something? All right, so disease injury. So I kind of have this broken down into the different disease processes and causes, and then signs and symptoms. So upper respiratory tract infection, also known as an engine company refusal. That's good. Thanks, Justin. Specific diseases would be the common cold, pharyngitis, laryngitis, and uncomplicated influenza. Trigger the immune and inflammatory response leads to mucus production, headache, low-grade fever, and general malaise.
Can you talk a little bit more about laryngitis? Is that a true emergency?
Potentially, if it was inflammation was bad enough. But are you looking for something?
Generating compensation. I mean, because yeah, we kind of did downgrade some of this stuff, but or downgrade or down talk some of this stuff. But laryngitis is, I mean, super close to the vocal cords, right?
Right.
Close to epiglottis. So I mean, we're not talking about epiglottitis here, but I mean, it could be a significant concern, right? If you come into a patient, Scott, who's a normally active, well-appearing, healthy male, and he's leaning forward and he's refusing to swallow, or it could be laryngitis, escalating into something more serious.
Yeah, no, I think that's a great point. And that's going to come down to our patient assessment. Does that person look dyspneic? Are they leaning forward? Are they, is it the epiglottitis type signs and symptoms? Are they unable to swallow? Or can you see that inflammation throughout their neck, or what? But yeah, definitely your patient population, and that influenza could be a lot worse for our older geriatric populations that we're running on most consistently, and so yeah.
And you talk about here leads to mucus production. I mean, kids, especially infants, can't control or manage their mucus as well as an adult can. So a simple cold for an infant who maybe was premature or has developmental delays. We had that one kid, Treacher Collins disease kid. That was the problem with him. He was over inflamed, producing enough mucus, and it ended up causing a respiratory arrest.
So it was backing up into the lungs, or
he was not
able to
occluded.
Wasn't able to clear it. He had reduced. It was a developmentally delayed or developmentally challenged child, and he was only 2 months old. And everything was reduced. Like he had a small pharynx, small vocal cord, everything was small. But he literally was seen yet the day before, and was diagnosed with what virtually is a common cold. But it was fatal for this 2 month old because of the problems that he was having. He couldn't clear his mucus, so mom laid him down, fed him, laid him down. 30 minutes later, he wasn't able to clear his own mucus and suffocated. So
kind of obstructed the airway, essentially. No, I like it. I appreciate it. Go down. Next on there, pneumonia. So pneumonia is getting into our lower respiratory, and you did have a couple slides on those, on the upper respiratory tract infections and versus the lower respiratory tract infection, the pneumonia, and differentiating the two. Next on there, I have pulmonary edema. So causes of pulmonary edema: heart failure, destruction of the capillary walls, and obstruction of the lymphatic system. So the lymphatic system can also back up. Signs and symptoms: lung sounds, orthopnea, and rowels, not crackles, and pink sputum. So you guys had a slide in there that said lung sounds can be confusing. Pretty much don't worry about them and treat the patient. I disagree with that slide. I think lung sounds are a pretty critical part of our patient assessment. I put rowels, not crackles, because my old instructor always said they're not crackles, they're rowels. But essentially we're listening to wet lung sounds. And I think there's only, I mean, you can get very technical with lung sounds and differentiating them, but essentially, are they wet or are they junky? And are they moving air? So, and are they clear? Another one would be the stridor upper, so location of it. I saw a pretty effective instructor at the symposium last year, and he talked about listening to lung sounds specifically on our obese patient populations. And he recommended almost, up in the armpit. So essentially he had a model stand up and drew where the lungs sat on the chest. And he said, listen to the lung sounds up on the axillary, because there's less adipose tissue there. You're going to hear into the bases, and you're going to hear whether or not air is moving. So those lung sounds are going to depict our care, in my opinion. So we'll continue on with kind of that treatment plan based on those lung sounds as we continue on here.
Do you have experience seeing very often the pink sputum? I've always noticed that to be very late and oftentimes associated with absent lung sounds.
Yeah. I think I've only seen it maybe once.
Yeah. It's usually absent lung sounds, and recognizing that you have absent lung sounds, and then asking them, hey, are you, they're coughing up, and it's pinkish or reddish.
I think it was shortly a respiratory arrest following it, but
that's usually pretty late.
Yeah. So, yeah. So treatment, O2, including CPAP. So we're pushing the fluids out of the lungs with our CPAP treatment there. So that's why it would be important to hear they're wet. Vasodilators would be good. Nitrates, give that fluid different places to go. And eventually intubation and diuretics. So I know you guys aren't intubating, but knowing the treatment plan down the road and what the next steps look like. So we said these are secondary to heart failure a lot of times. So one of the medications you guys are going to be getting is albuterol. I heard Gabe talk about this is a sympathomimetic. I think of it as it's mimicking the sympathetic nervous system, right? It's increasing the workload on that heart. So this is a medication that you do not want to use in someone with heart failure. Fluid's backing up into their lungs because their heart's not working effectively. We don't want to increase the workload of that heart. It's already not effective for us.
It's super important to understand what lung sounds you're listening to, because there's a significant difference between a wheeze that would be indicated for an albuterol and a Rawls or a bronchi that you may want to, continue your assessment, get more down before you administer albuterol treatment to that patient. Mm-hmm. Is there pitting edema? Is there, just do a more thorough exam? Because I think that's something that we often do. While they're having trouble breathing, we just want to help them, because that's a high anxiety situation, even for us as a provider. And we just, we have to make sure that we're doing our thorough assessment.
So a lot of times that's that patient that we say that is dyspneic. So they are working hard to breathe. So we quickly want to treat them. So we throw something at them. We throw an albuterol treatment.
So you saying that you're able to hear the difference between the lung sounds, or you're just obtaining the history and looking for the
You should be able to hear the difference. So,
unless it's super late and they're increased to the point where you're not hearing much of anything. And then, are these guys allowed to use Untitled? I know we talked about that a couple of years ago. Do they use it not interpreted, or?
We can use it. Yeah, absolutely. I think it's in.
Well, we have the pop on, but we have
They're in
in
the
our
nasal.
scope.
oh,
Yeah.
colorimetric?
Uh-huh.
Yeah, but where else?
We can use it in our nasal cannulas
Right.
and see the waveform on our monitors.
Exactly, that's good.
I'm not saying that we wouldn't be able to read them.
Right.
We're looking at the scope.
That's just another tool to use.
Basically, you could interpret it, but
We can look at.
Another good tool to use to distinguish between is this COPD, or they having a bronchospasm, or they having heart failure. You didn't see that bronchospasm or the heart failure patient. So just think about that too.
Okay.
so
So,
CO oximetry is a bit
advanced level.
per our protocol.
All right. Good. All right. So next on here is COPD.
if I could just one more point on the talking about treatment, O2 including CPAP. Well, CPAP is going to be fantastic for these patients, and often we'll turn them around. But if CPAP isn't working, and while you're not, as an advanced provider, responsible for the innovation, I mean, if we're doing CPAP and then we intubate this person and then just put them on BPM, are we continuing the positive pressure? What else can we? Yeah, peak valve, right? So, and that's something that you guys can be super helpful with. I know for me personally, sometimes that's a forgotten aspect. There's so much going on. I've got medications I'm worried about, Entitled, all this stuff. And if I just had, Warren like whisper in my ear, hey, think about peak valve. Oh, yeah, absolutely, because this is CHF. So let's go ahead and continue that process of cleaning out those lungs, pushing that fluid out and through a peak valve. So understanding what the CPAP is in your scope and understanding what that is and how to continue that, no matter whether they're intubated or not intubated, I think is critical to your scope.
And I think about these interventions, prior to an ambulance or paramedic there, if you're on the QRU, get that CPAP going early while you're in the house. And we can say, hey, you guys are just getting here. We've seen that this hasn't helped them at all for, the last 5 minutes. And I can be thinking, well, this is going to be a lot quicker what our next step is. So getting those interventions.
CPAP you can use for your CHF patients and your COPD patients. So that's one treatment that if you're not 100% sure, that one's going to be okay to use, but the albuterol is not. So if you have a CHF and a COPD, or you're like, I just don't know, I'm just doing albuterol treatment. The albuterol treatment could make your heart failure patient worse. So think about that.
Okay.
And one other point is a lot of these COPDers and CHFers could be DNRs. So we'll just medical come and intubate them. A lot of them are not to be intubated. So you want to make them more comfortable, and CPAP, if you do it early enough, is going to help them. It's probably going to, it should turn them around. So just think about that. CPAP's a great.
So that's perfect. Going into our next line is COPD. So everybody says, oh, they're COPD, and you think of that as like a disease process, but that's like the overall title, if you will. So COPD stands for, nailed it. There you go. So COPD disease processes can include like chronic bronchitis, emphysema, even like Pickwickian syndrome, even like an asthma is an obstructive pulmonary disease, but it's not chronic, so it wouldn't fall under that title. So that's kind of something to think about is which one of these COPD, which one of these chronic obstructive pulmonary disease processes is it that this person has. Something else with COPD, after about 10 years, there's a 50% mortality rate. Fun fact. So on that exasperation, they're already 50-50. So chronic bronchitis, obstructive pulmonary disorder characterized by excessive mucus production in lower respiratory tract. It's got to last for at least 3 consecutive months of the 3 consecutive months of the year for 2 consecutive years. So the patho, excessive mucus, decreased, I have a blank there, cilia function. And number 3 is increased infection. Did you guys get that? Cilia and infection. And then next page, we got chronic inflammation of the mucosal lining. And all of these above processes lead to air trapping. So they increase mucus plugs, trap air there within the lungs. The next one I have on here, so this is another COPD disease process, is emphysema. These are also known as pink puffers. Chronic obstructive disease characterized by loss of lung elasticity and alveolar surface. So some of the patho, the loss of elasticity is secondary to, and I have a blank for you there, destruction of elastic and collagen fibers throughout the lung tissue. So it's essentially, destruction of elastic and collagen fibers throughout the lungs. So essentially they're building up scar tissue. So you get that chronic inflammation. Think of someone who's scratching out that redness. It's got to start healing, and that healing process over and over again creates that scar tissue. There's not a whole lot of elasticity to that scar tissue. So you think of like a burn patient with a circumferential burn at a real young age. A lot of times they got to go in and surgically open them back up so that they can grow, because their skin can't respond with all that scar tissue around it. Second one, damage can occur secondary to chronic inflammation response. All right. So different causes of decompensation. Respiratory infection takes this population out. Non-compliance with their medications is B, medications. Cardiovascular deterioration, hypertension, smoking, and then E is noxious environment. So noxious environment for our populations can be like the fires in August, the increased smoke in the air. I had another line there, but I don't remember what it was supposed to be. Moving on. Signs and symptoms, exertional dyspnea, chronic productive cough, tachypnea, tachycardia, which we just talked about, increased respiratory rate. E, pursed lip exhalation. So what's our patient doing when they purse their lips during exhalation? Yep, pretty much creating their own PEEP valve, right? And G, put rhonchi. So rhonchi, when we're listening to lung sound, it sounds junky, like it's mucus in there. So you think of just a lot of crud, if you will, when you're listening to that air moving through it and the mucus flapping around. Find these patients in a tripod, and then do our treatments. So we're talking O2, CPAP, eventually intubation. And you guys have been given albuterol as a treatment. And so that's bronchodilation. Another thing we can use use is the anticholinergic we carry. That won't be in your guys' scope. Do you guys remember what that was, though? Yep. Atrovent. So you talk about ANA, albuterol, and Atrovent. It's the other half of that. So we talked about the parasympathetic nervous system innervating the constriction of the bronchioles. So an anticholinergic is going to inhibit the parasympathetic nervous system, which should help relax some of that bronchial constriction when we give that. These patients could end up needing some steroids to help with some of the inflammation. So then we move into, are you guys good? You need a break? Handstand, cartwheels? Okay. Asthma. So there, if you want to put in the margin off to the left side, there's 3 pathological conditions for asthma. First one's going to be bronchospasm. The second one is going to be thickening of mucus, an increase in production. And then 3 is the formation of plugs. Essentially, formation of plugs, so mucus plugs. So I got it broken down into 2 classifications, extrinsic versus intrinsic. The intrinsic's more irritants, where the extrinsic is where an exterior antigen is introduced into the system, which stimulates immune system response. So mast cell activation, you get the degranulation of the mast cells, and that releases your histamines and your prostaglandins. So under some of the patho, obstruction is going to be secondary to bronchial constriction, which is your first blank. And then your second blank in there is going to be mucus plugs. And then the hypersecretion or inflammation. So those 3 things I had you write down there in the side there. Bronchial constriction, mucus plugs, and hypersecretion, inflammation, your mucosal lining. Bronchial constriction is caused by the vagus nerve. That's B there, vagus nerve. And then, do you guys know what acetylcholine is? It says bronchial constriction caused by the vagus nerve releasing acetylcholine and subepithelial irritants. Acetylcholine is the parasympathetic nervous system neurotransmitter. So I got consequences of airflow obstruction, so increased airway resistance, edema, mucus, and decreased airway diameter. So that would be your bronchial constriction. All right, next page. So what? So we were talking about lung sounds earlier, so I'm looking at the signs and symptoms, and under there I have wheezes. What causes wheezes when you're listening to lung sounds?
Constriction of the airway.
Right. Which is an indication for what treatment? There you go. Other things we can look for: previous medical history. Do they look dyspneic? Or dyspnea is that actual increased work of breathing. That patient that we see leaning over and working to breathe. Treatments for these patients. You can give them some oxygen. Beta-2 adrenergic drugs. It's going to be our drug of choice. That's going to be our albuterol. So an asthma patient is a patient that you can have a very big impact for, especially being if you're on the QRU or a quick response, waiting for that advanced provider to get there and get a breathing treatment. So we were talking about not just throwing a breathing treatment on everybody. We've heard from the signs and symptoms. We have wheezes present. We're going to treat this patient specifically with the albuterol, the beta-2.
Somebody's prescribed an inhaler for albuterol. When would you want it? Is there a point when you just want to forget about it and just use your own, or would you always try theirs first and then go into
If we're called for an emergency, my response is go directly to ours. One, we know it's not expired. We know our delivery system's good, and we have some different options. We don't have to necessarily talk them through if it's exacerbated to the point where they maybe aren't holding they're shaking and they're having trouble holding that MDI. And if they have one on them and it's probably not working. So we need to start thinking about, why that might not be working. Like, is it the delivery system? Is it expired? Is it out? And if they have that, if they're having that significant of a response or that acute exasperation, then I'd say probably just go with ours. Plus, we can put it on like a non-rebreather. We can do different things to keep it readily available to them. Yeah.
Are these patients kind of like COPDers in the sense where they're air trapping, so they're retaining CO2, but do they also, because of that bronchial constriction, do they trap air and kind of auto-heat themselves in that sense, or is it just essentially that they just can't move enough air because of that constriction, and they haven't necessarily I know, as a kid, I had a couple of really bad asthma attacks. You just end up breathing in because you can't feel it feels like you can't breathe at all. Everyone knows that, but is it? I guess what I'm trying to figure out if it's a PEEP issue.
Eventually it is, right? So it can go to a CPAP. So initially you're getting that bronchial constriction, right? And part of that is going to start to create some anxiety, and you're getting that initial response. So that anxiety is going to stimulate your parasympathetic nervous system. So you saw the other day that SLUDGE acronym. You're starting to get that. You're getting that increased mucus production and that inflammation. So that's kind of the secondary problem with some of these asthma responses if they're persistent, is then you're starting to trap the air, yes, both with the bronchial constriction and the mucus inside the lungs. So we can treat that initial response by treating that bronchial constriction with albuterol. But then if they're into that secondary portion of it, that's when we might have to start looking at like a CPAP. Because yes, then you get that atelectasis like we were talking about, where that trapping of air, you get it diffused out of those alveolus, and now you're getting, potentially collapsed lungs. And so
I'd always heard that you can also try to assist the exhalation
with a little bit of pressure. Yeah.
Have you ever seen that or done that in the field?
I've never done it or seen it. I've heard it, but I think we're better off utilizing our PEEP valves or CPAP and getting that index expiratory pressure. Yeah, so continuing on they're on our treatments. Think about IV fluids. So you're getting all that mucus production, and people are probably getting a little bit dehydrated, and you can help with it on that roundabout end. That'll be more long term that they'll see the benefits of that in the hospital. But You know, if you're giving this person some pathomimetic, I'd say go ahead and start an IV. Give them some fluids. Don't just give them the breathing treatment and see if they improve. Go ahead and prepare yourself if it doesn't improve them, or the next provider coming in with getting an IV going. And so, anaphylaxis was on your list and in your slides. I guess as far as respiratory emergencies, they're probably more worried about like someone with angioedema or something, the constriction of it. But treat that like an allergic reaction, right? It's systemic response. Get them some epi. So spontaneous pneumo, so spontaneous pneumo is a collection of air in the pleural cavity without trauma, made to develop due to a rupture of pulmonary bleb, which is chronic inflammation, or can be caused by excessive ventilatory pressure. Under etiology, these are usually men, so genders, they tend to be more gender specific. And then B is they're usually like a tall, thin male in their 20s to 40s. I actually saw one of these the other day. That patient, Pete, had taken him in for a spontaneous pneumo. And I thought, how did this guy get a pneumo? And he's in his 20s. But anyway, I think it might have had to do with, if you look at D, I have excessive screaming, coughing, Valsalva, or drugs with deep inhalation. I think it might have been the latter of those options that inflicted this spontaneous pneumo for this individual.
Like similar to, because I know you said like the tall, slender, gender, like predominantly male, like pleurisy, same thing. Is that just like a precursor to spontaneous pneumo? You have that like rather than one name?
Maybe if the right irritant was in there and then exacerbated with one of those other causes,
I had a friend that fit that bill, tall, slender.
Yeah.
He went snorkeling and he went down like 20 feet, spontaneous pneumo.
Really?
Yeah.
So what's Valsalva? Could be. It's like breath holding. So like kind of have people do that for like trying to get that vagal response sometimes, right? Anyway. So signs and symptoms: short of breath, pleuritic chest pain, pinpoint, sub-Q emphysema. Complication would be if it started tension, coughing up a blood. There's not a lot we're going to do for these guys. Supportive O2, manual ventilations maybe, probably not. Pleural infusion, you guys had a slide on it. So there's copy-pasted instructor notes on what your book wanted you to know about pleural effusions. And I'm going to get some more coffee. 5. Pause.
He's all big question. He's like, he's single. Taking notes. And then we were just talking about respiratory acidosis, and it was breaking down the point where, like, I guess you build it like carbonic acid when obviously the retention of CO2 and the water in the bloodstream mix, right?
Mm-hmm.
So is that what we use Is there a bike ride for it to reverse that process?
So it's not going to reverse the process. It's going to help buffer it. So that's your buffering system. Let's touch on that in a little bit. Okay, we'll get started here. But yeah. All right, guys, I got. We're gonna open with Rusty's abs here, and then we got 2 more pages here that I'm interested in, and then we'll work on this worksheet, and I think we'll be done out of here. So should go pretty quick. PEs. Does anybody know what PE stands for? All right. So blockage of pulmonary artery by a clot or other foreign object. Different causes of PEs. A is increased coagulopathy, and we're going to see that in smokers, or what's the population we always worry about it that we usually don't think of it? Younger females that are smokers and on birth control, yeah, BC or contraceptives. B there, I have another blank. So smokers or contraceptives for the first one. And varicose veins for B. Just the pooling of that blood in those veins makes you at higher, B is varicose veins. So higher propensity just from the pooling of the blood down there in those lower extremities. C, childbirth. D, cardiac disease. And E, like a venous injury. Venous injury. A little better. As far as the injury, it depends on where that clot gets dislodged to or goes. You know, as far as pulmonary embolism, they could have a small one and it could respond to them. But essentially, you're getting that clotting process from an injury, and part of it breaks off, and it's going to need to go somewhere else. And PE had just ended up in their lungs. It wasn't dissolved by the rest of their body. Example below that, the trauma, long bone fracture, large vessel burns. Obesity, honestly, I'm not real sure on how the obesity correlates. I'm assuming just because they're a little more sedentary. And just, what are some of the other things you hear? We hear people who have traveled recently. Why is that? Recent surgery. Right. Yeah. Yeah. Desk jobs. Yeah. Obese people doing desk jobs. Yeah. Right.
Or you'll get like a scenario where a lady has like a boot on or whatever.
Yeah. Yeah. Yeah, it's a recent one, airplane flight, major surgeries, smokers, contraceptives, PEs. Cystic fibrosis. Oh, signs and symptoms on the PE. The kind of classic one is you hear of chest pain that is pinpoint. It's right here or here. I've never heard it, but they say localized wheeze at site of pain. And you're going to get the tachycardia, the anxiety, right? Feeling like you can't breathe. It's going to be a pretty common response for a lot of the exacerbations of any of these disease processes. Cystic fibrosis. Yeah, I mean, treatment on these patients are going to be tough, right? They're going to need potentially fibrinolytic or oxygen or time, or I mean, so it's going to be a hospital treatment, but ours is going to be supportive. So, no, pain management would be a great one. working on differentiating, is this cardiac chest pain, or is this, does their history allude to that this could potentially be a PE? Do they have that classic pinpoint? Do they have one of those signs and symptoms?
Possibility of like decompensating pretty quickly, right? Because it can lead to cardiac arrest pretty fast. Right?
Yeah. Yeah, and obviously if they go into arrest, treat them CPR. I believe that's what happened to Brandon Erickson down there at Eagle Fire when they lost him. He just had back surgery from on-the-job injury, and his mom was at home with him. She heard snoring stop, went in there, and he essentially had thrown a clot and had pink froth coming out of his airway. And those guys had to go work him. So, yeah, they can definitely lead to cardiac arrest. Cystic fibrosis, common disorder characterized by excessive mucus production due to excessive production of thick mucus by the exocrine gland. Primarily affects the lungs and pancreas. Life span of these, so this is going to be something they're born with. It's a disease process. They're going to have dealt with it for a long time. The expectancy on this patient population is about maybe in their 30s. So this is going to be someone you show up on. Family's been dealing with it. They're in a hospital bed. Ran on one a long time ago. I think it might have been up in like Spirit Lake or something like that. And the family was very familiar with the process. They had recommendations. I believe she was trached, and they recommend, we can suction this way. And there's not going to be a lot we can do for them. But it's definitely qualifies as COPD. So air trapping, which leads to, talked about it earlier today, atelectasis, eventually the lung collapse. So they're going to be prone to bacterial infections because of the increased mucus. And eventually the right side of that heart's going to work a lot harder, because they're going to lose compliance in those lungs. Most of these patient populations will be diabetics. Other GI effects, blocks bile ducts, malabsorption of fats. If I do remember my patient, she was pretty thin, pretty small. One treatment that I've only probably used it a handful of times myself is I'll just nebulize some saline, and just getting some of that humidified air in there can be real helpful for a lot of these patients with different mucus problems. Just creating some of that moisture in there and loosen things up for them.
Parents of cystic fibrosis kids are going to be really used to the cupping process, and it's where you literally cup your hand and you will hit the back of the patient, and it has an opportunity then to break loose some of those obstructions that these cystic fibrosis kids have. So if you get in and you see them literally cupping their back, know that they're doing exactly what they need to be doing, and they're going to be the best ones to help you through the process of treating these kids. And this is right on. It's usually it's going to be a younger patient's issue, and the family's going to be your best source of information.
Yeah. Moving on, we got fine print, which means I copy and pasted it out of the instructor notes for you guys from the slideshow. So slideshow had a slide on each one of these with a list of talking points. Let's go to my little chart. How many got? 1, 2, 4. Let's break up into, let's partner up, and each partner, let's do it per table. So Robert, you and Rusty work on acute pulmonary dyspnea, that first box, and Shay and Ryan, if you guys want to work on the next box, maybe go down to COPD, and then just kind of use some of this outline to fill in some of the spots, and then we'll spend like 10 minutes of what you think might fit in the boxes, and then we'll talk about, we'll kind of brainstorm together.
Give instructions to the people that are watching.
People at home, if you go to your last 2 pages, I got some blanks in there, and it's broken up into the disease process. And so fill in what kind of history that you'd expect this patient to have, what your findings might be, and what your treatment plan would be. Mm-hmm. Yeah.
Pinpoint.
We bonded something special. C.
Mm-hmm.
Teacher sick. You buddy?
I'm about ready to go on vacation.
Oh, you leave today?
No, Sunday. I'm gonna run up. My brother's in town from
Oh, is he?
China, so
Is he sleeping right now?
he got back a couple days ago, so he should be feeling spry. Yeah.
Resting a little bit.
Yeah. What's that?
Moab?
You leave Sunday to go.
Yeah.
Bike.
Yeah.
That's awesome.
You're gonna Moab?
Sedona.
Oh.
Yeah.
That's right. You did that last year too. Didn't you?
Yeah.
You
Yeah.
don't bring a bike. You demo bike there.
Yeah.
That's when you came back and you're like, I'm getting a new bike.
Might have been. Yeah.
Is it
Yeah.
think we can do
Cystic
Fibrosis.
Yeah.
I don't think we have a transport.
Oh, you're gonna get going to this.
All right, guys, you guys ready to talk about these? We'll put our heads together. All right. Pulmonary embolism. So we just talked about the PE, and we talked about recent trauma, blood thinners. Just came up, and I think it's a good one. Prolonged immobilization. Anyone else have anything? Recent surgery, yeah. What would be some of your findings? Good. Chest pain, acute pinpoint pain. Something that, yeah, talked about. So as far as treatment, CPR to oxygen. Yeah. What are the blood thinners? You guys know all the blood thinners? What are the main 4 blood thinners? We should all know these. We get asked every time. Are they on a blood thinner? So Coumadin and warfarin's the same thing. Pradaxa, Eliquis, Xarelto. Right? We all should know those. I got to remind myself because I'll forget. Pradaxa. So moving on to asthma. So I have prolonged exhalation. Are they exercising? Do they have a history of allergies? Do they have their own MDI? It's EMT basic. What's an MDI? There we go. What are our findings? What are Yeah, so when we're doing our physical exam and we're listening to our respiratory patient, because that's how we assess the respiratory patient, what are we going to hear? Yeah, absolutely. And how can we treat those wheezes? Albuterol, yeah. Also put in there up to CPAP and potentially even epi. Pneumonias. So pneumonia is going to have a history of infection. What's a finding with the pneumonia? What would kind of differentiate? So we're going back to our physical exam and we're listening to the patient. They're going to have a fever, right? It's an infection. What might differentiate it if we're listening to the left and the right side? Yeah, a lot of times it'll be left or right-sided, so they'll be asymmetrical as far as your lung sounds. Unless it's real advanced, maybe it's potentially spread to the other side. A lot of times that'll be kind of a different, help you with your differential. What can we do to support a pneumonia? Yeah, give them some fluids, right? They got an infection. They're going to need some fluids. Oxygen helps them. If they got a wheeze, we know how to treat those. They might be someone that could benefit just from some nebulized saline too. Help break some things up for them. Foreign body. So who's going to get foreign body? Yeah. Old folks. Me when I eat too fast, right? Like, so that's usually age dependent, geriatric or pediatric. Another thing, dysphagia. Difficulty swallowing. Dysphagia is difficulty speaking. Difference in spelling. No, they could also be someone who has something unilateral or stridorous. So stridor would be upper airway, unilateral. Talk about intubations. You don't want to go too deep because you'll right main sternum. Potentially, if that foreign body was aspirated, it would potentially go to the right side because it's a straighter shot for him. So when you think about your lungs, you have different lobes, right? You have 3 on the right side, 2 on the left side. There's got to be a little bit of room for the heart. So your bronchial, when they bifurcate the cornea there, they're at a little bit of a different angle. So you might find them more on the right side. What are our treatments for that potentially? Depending on how deep it is. Yeah.
That's all, yeah, like what stage if they're like choking, you get all hydraulic.
Abdominal thrust? Yeah. No. Yep. So potentially getting your airway kit out, if there's not an advanced provider there, getting the Magales out, having these things. We had a CPR the other day, and the lady was like, well, we got choked on a strawberry. There's a strawberry in there somewhere. So immediately look for the strawberry. There's no strawberry. Just went in cardiac arrest. But I was ready with some Magales thinking, what am I going to need to get this out? Obviously, that's a little different scope, but preparing preparing for that and thinking these are the things we need to get out and get ready is important. So non-cardiac pulmonary edema. Anyone fill anything out for noxious gas inhalation? So they're going to have a history, right? Part of that history is going to be some sort of exposure. What were they exposed to? A lot of times on your findings, it's going to be burning of the mucosa, create some wheeze. So maybe you get some bronchial constriction as a reaction to whatever they were exposed to. You might hear a hoarse voice, something like that. Potentially what they were exposed to, yeah. Yeah, I mean, if they're becoming hypoxic or something like that, or, you know, anxious or can't breathe, you know, you're going to see some changes there. So supportive, right? We can nebulize some saline, give them some oxygen. But it's going to be important to dig into that history a little bit and figure out what they were exposed to. I mean, it could even be a poison control call or placard, hazmat. It's kind of out of my wheelhouse. So. Next one, COPD. This is, yep. Yeah.
We should have a last right by just this way out of the way it presented was
Yeah, no, it was just like what you were saying. There was a cardiac arrest, and we get there, and basically the guy was on his back. It was an elderly gentleman, and the wife didn't really have any history for us, so we presented with the guy on the floor. What looked appeared to be like agonal respirations, you know, kind of like the fish out of water, kind of gasping, kind of.
Yeah.
And we go right to feeling a pulse, couldn't feel pulse, so like we're all trained, no pulse, just CPR. But he just had these weird like gasping, agonal gasps. And as soon as we started CPR, after like 30 compressions, the lady breathed out of DNR. And so we're like, okay, we'll stop everything. But we got as far as just doing compressions. There was airway stuff was just getting out. We didn't have a chance to like bag or opiates or anything, so the airway was just left there. And then it came about a minute later. He was like, yeah, I don't know what happened. He was eating his apple and he fell over. So Cody on Medic 31 was like, all right, well, that's weird. Let's look at his airway. Because we didn't get to the point, you know, if we would have started bagging him film resistance or whatever,
right,
we would have been like, oh, obstruction. But yeah, sure enough, he took his laryngoscope and his McGill's and pulled out like 3 huge chunks of apple. And then his pulse was just right back. And he instantly started kind of opening, becoming more reactive. And by the time they got him to the hospital, he was like alert and talking.
No kidding. It's a good one.
He just shows to show how like, he was completely certain. Like, he had no radial or carotid pulse. Like we barely felt like a super, barely thready femoral pulse on him.
Yeah.
And that's kind of what started us to look. Because otherwise, we had the DNR, so we probably would have just called it right there.
Right. Oh, that's a good one. That's good, thorough history, right? Hey, what were the events leading up to it? Back to even your sample history.
I learned too, just like we all see like agonal and like CPR people present differently, but he definitely had the more like I'm trying to breathe here, not just these weird kind of gasps. So
yeah,
just always remember, yeah, for me at least to show people there's a possibility.
Right, thorough history. Nice. But I mean, that's what it's going to progress to. If the Heimlich's not working, right, we're going to CPR. So.
Yeah, the lady wasn't with them, didn't know what was going on.
So. Yeah. So emphysema. So all these I got listed under here. These are all COPD, right? You guys heard of Pickwickian syndrome? Yeah, it's just your obese patient. They are so big that the weight on top of their thoracic cavity won't allow them to expand it. So a lot of times they're going to be positional, need to sit upright. You lay them back. We lay our gurney back to scoot them up, and all that weight comes down on their chest, and they can't breathe. So sitting them up, mechanical ventilations, that could be just the BVM, that could be PEEP valve, CPAP, any of these things that help expand that thoracic cavity for them. Emphysema. What's an emphysema patient look like? Yeah, nasal cannula, cigarette. Throughout the house, you trip on the way in. Yeah, we all got that image, right? So they're a lot of times called pink puffers. So they have polycythemia. They have an increased production of red blood cells, so they kind of get that pinker look to them. So their recoil in the lungs aren't as good, so they get that barrel chest, because all those muscles are working to push that air out. So you hear about that mechanical ventilation of the pressure on the chest. That would be the type of patient, even though I've never seen it actually put into practice. But yeah, the findings. What are you going to find on a COPD or other than oxygen tubing?
First, insertion, sinuses.
Nice. Perfect. Yep. Pursed lips, wheezing, maybe a dry cough. Our treatment for them would be neb, CPAP. Bronchitis. Does anybody know the nickname for bronchitis? Sometimes they're called blue bloaters. Blue bloaters because they're a little bit cyanotic. So they're going to cough with sputum. But it's just that chronic inflammation, mucus, lung sounds, some bronchi. That junky mucus sound you can hear in there. Treatment for these guys, CPAP, maybe a nebulizer. Back to cystic fibrosis. So these guys are usually, like we talked about the history, they're usually young, hospital bed, probably with family. They're probably not very self-sufficient. Sometimes you'll find they'll have like club fingers, being acidotic, and all the CO2 retention that they get. And then, like Chief talked about, the cupping, nebulized fluids. Thanks, bud. Yeah, absolutely. Yeah, you give them fluids and help rehydrate them. Some nebulized saline, potentially suction. Upper airway obstructions, covered those pretty thoroughly. Potential treatment for upper airway obstruction. If it's secondary to like allergic reaction, if it's anaphylactic, be looking at like Benadryl. That would be an upper airway obstruction, all that angioedema, inflammation. Cardiogenic pulmonary edema. So the type of history we're going to have on cardiogenic pulmonary edema is they're going to have a history of Lasix, right? They're going to try to, so Lasix, they're trying to get rid of some of that extra fluid, trying to empty that container a little bit because that pump isn't able to move it like it needs to. Some orthopnea. What's orthopnea? There we go. So we take orthostatic blood pressures, right? Orthopnea is shortness of breath when you lay them down flat. Essentially that fluid in the bottom of their lungs spreads to the top when you lay them down flat. so they aren't going to tolerate that supine positioning very well. We might find these people to be on some beta blockers. Signs and symptoms, wet lung sounds, and CPAP and nitrates. So I didn't look at your guys' scope of practice. Are you guys able to give nitro with?
Nitro?
Give nitro? If it not within our protocol as far as chest pain only. They probably have a little chest pain with that shortness of breath. Yeah, so hyperventilation syndrome. I put in there, you got to rule out respiratory, but it's kind of a diagnosis of exclusion, meaning it's about all there is to it. They don't have any disease process going on. It's more anxiety, so coaching of breathing. That's about all I got for you guys. The slideshow talked about patient assessment. I think it's easy for us as far as patient assessment to go to the tools we have. So we talked about Untitled, we talked about SpO2 monitoring. I think it's real important to get your hands on these patients with your stethoscope. I think it's, that primary impression, that initial assessment of looking at how hard this person is working at breathing tells you a lot. I was listening to a podcast the other day and they were talking about using a stethoscope, and our patients expect us to use a stethoscope. They've been going into the doctor since they were a little kid, and the first thing the doctor does is he gets his stethoscope and puts it on them. So if we can get into that similar practice, people expect that when they are calling for a medical emergency. So go ahead, put your stethoscope on them. They expect that as part of their health care. And that'll help us get familiar with our lung sounds and be able to differentiate better where it's most effective, what we hear in different fields. And so that would probably be the biggest part that I'd encourage you to do. And then once you've listened to those lung sounds, once you've taken in their presentation, then start using those tools that we have for us, get them on the SpO2, get that room saturation, and collecting that history. So
our protocol does say that we can give nitroglycerin as long for pulmonary edema.
So it is indicated for pulmonary edema. So
even at the EMT level, you can assist.
So then the nitrates they're making the container bigger, right? So that's, like I said, it's backing up. So vasodilation gives that fluid somewhere to go. Other than that, that's about all I got for you guys. You guys got any? And hopefully this handout is just kind of another tool to study with. A little different look at it for you.
Thanks, Fritz.
No.
Thanks.